reproductive health and rights. My name is Rita Morbia, and I work at Interpares. Interpares, which means Among Equals, is a feminist social justice organization in Ottawa that believes in solidarity as an approach to international cooperation. Our office is located in Ottawa, and I'd like to begin by acknowledging that the land on which many of us live and work is the unceded territory of the Algonquin Anishinaabe people. We pay respect to them as the original guardians of this land and thank them for their stewardship, with recognition of their long-standing relationship with this territory. Les présentations aujourd'hui sont en anglais, mais vous pourriez poser des questions dans la langue de votre choix. Ma collègue Marietou peut traduire si nécessaire. We will be recording the first part of this webinar with the presentation so that we can share it more broadly, but we will not be recording the Q&A. For this reason, during the presentations, we invite you to turn off your camera and also to be on mute. But once the presentations are over, please feel free to turn your cameras on again, and we'll have a discussion. Okay, now to move on to introductions. Interpares and the Likaan Center for Women's Health have worked together since Likaan's founding in 1995. It is a relationship of common cause based on shared feminist values, collaboration, justice, and so much more. We're delighted to have 4 colleagues from Likaan here today. Dr. Janice Melgar, the executive director, was going to do an introduction. She is here, but she is recovering from COVID, so we're just going to let her off the hook for now, and she'll just be present to answer questions.
TMTG's investor program.
We're really happy that you're recovering, Dr. Janice. In her stead, to do the first part of the presentation is Joy Salgado.
Technical infrastructure that
Joy is a founding member of Likaan. She's a key player in the establishment, growth, and strengthening of the Reproductive Health Advocacy Network, an NGO network.
No, it's a fucking...
And the main force behind the successful campaign to pass the reproductive health law. Currently, she heads Likaan's advocacy unit. Also present from Likaan is the intrepid Ronit Susi, finance coordinator of Likaan and the youngest member of the management team. She's successfully managed and overseen the financial aspects of several large partnership projects in the last 5 years. And last but never least is Alfredo Melgar from Likaan as well. He's the lead researcher of Likaan and a key proponent of Likaan's thrust to establish the Philippines Department of Health and PhilHealth accredited clinics to promote sustainability. And you'll be hearing more about those entities and what that accreditation means through the presentations. And our moderator today is Dr. Jeannie Samuel. Jeannie is an interdisciplinary scholar with a PhD in public health sciences from the Dalla Lana School of Public Health with expertise in health equity and human rights. Currently, she teaches at York University in the areas of environmental health, health and humanitarianism, and gender and health. Jeannie also pursues a research agenda focusing on different types of human rights-based accountability mechanisms for addressing health inequities faced by marginalized peoples. We're fortunate to have Jeannie on the Interpares Board of Directors and as moderator for today's discussion. So welcome, Jeannie, and I'm going to turn it over to you.
Fantastic. Good morning, everyone, and thank you, Rita, for the introduction. So it's such a pleasure to be with all of you here in our virtual space. I guess we're all getting used to the virtual space 2 years in, but I'm excited about the conversation that we're about to have, and I'm so grateful to our colleagues in the Philippines for joining us and being part of all of this. So I want to just limit my remarks to a few things I hope we'll keep in mind as we move forward. I'm just going to talk for a couple of minutes and then I'm going to turn the floor over. And so I just, in terms of framing our space a little, I'm naming the elephant in the room that has been on all of our backs for so long, just thinking a little bit about the work that is happening around sexual and reproductive health and rights in the context of COVID-19. So I want to just emphasize the incredible impact, negative impact that COVID-19 has played on SRHR. A recent study in the Lancet Global Health noted, and this is, I think, no big surprise, but the studies are now coming out that back it up, that, for example, in the area of maternal mortality, they talk about global maternal and fetal outcomes having worsened during COVID-19, in particular, increased maternal death, stillbirth, ruptured ectopic pregnancies, and maternal depression. So clearly, we're in a difficult time. We also know, and Canada is such a big, important champion of the Sustainable Development Goals, and we know that COVID-19 has certainly been playing a role in potentially backtracking our progress on those issues. And that's, I think, for all of us in the room, of particular importance when we're thinking about goal number 3, health and well-being, and some of the particular targets that are associated with the work we are talking about here today. So in particular, reducing global maternal mortality to a ratio less than 70 per 100,000 live births, access to universal health coverage, which is a massive and important piece of this puzzle, and ensuring universal access to sexual and reproductive health care and services. So all of those pieces are certainly even more fragile than ever. And at the same time, and I think this is really part of what we can be talking about today, we also are starting to hear about potential and opening, because with disruption and big disruption that something like COVID brings, maybe a silver lining in that is new openings and new potential for us to think about change. We are hearing words like an SDG push. How could this be, this moment of COVID-19 be a new and renewed time for a push towards the SDGs? And within that, I think we have a lot of things to consider and to really grapple with in a critical way around big issues, and in particular around modes of financing. And we are all interested in ideas around innovative financing. But what exactly do we mean by that? There are so many different ways of interpreting it. And I think that's part of the puzzle and part of what's possible in this type of conversation. So I think that as we start out and embark on 2022, I can hardly believe we're at 2022, and we think about the SDGs. I started to work, I was working with the United Nations back in the late 90s. And when I first began as a newly minted program officer, at that time, we were just launching the Millennium Development Goals, and 2015 seemed like a long way away. And so here we are in the new improved version with the SDGs, and somehow 2030 is around the corner. So it's in that spirit that I turn over the floor to my colleagues from Liika-Ann to share with us the work that they're doing around a very innovative model for SRHR. And just offer it up to you as something that we can hopefully talk about after in as open and frank a manner, and ask each other questions and really grapple with the kinds of questions we're trying to deal with this morning. Okay, so on that note, I'm going to turn the floor over to Liika-Ann, starting with Joy. And in terms of moderating, I will have all of you please from Liika-Ann just move through your presentation together. And then I will pull together some summarizing remarks. And afterwards, I'll open up the floor for questions to everybody. And we've left ample time in our agenda for questions. So there will be, note them down, please. You'll be able to put them in the chat, etc. And we'll have lots of time for a discussion. Okay, thanks very much, everybody. And Joy, I turn it over to you, please.
Hello. Thank you, Rita and Jeannie, for the warm welcome and introductions. Good morning, everyone. Can you please share our presentation? Thank you, Marite. Okay, our presentation on developing a sustainable funding model for sexual and reproductive health care will be in 3 parts. The first part is about Liika-Ann, The second one is our experience with with the 4 gap supported clinic, and the third, the context and future of sustainability. Now let me do the first topic. Next slide, please. Haan is a feminist NGO for women's self and reproductive health. Our approach to social change is lifelong. Our 3 core programs are clinic services, community development, and education. These programs are interdependent. To illustrate, next slide, please. We have 7 clinics accredited by the Department of Health and Human and 6 more regular service delivery points. Our clinic services generated 50,000 consultations per year in the last 2 years, while our organizing work mobilized hundreds of volunteers to community. Our work in our advocacy work, Haan is elected CFO representative, and Haan also has the and the general policy of next slide, please. But despite the RH law continuing that conservative opposition for SRHR well as the national government continues to back and back funding art. This despite the bank actually that 46% of women are wants to space or maybe their children are not given money, while 20% are advantage. Percent are mothers or when if the kids become country public, ensure that our programs, the poor and most SR services, we purposely located our clinics and organized events. One of our clinics in Manila can reach more than 100,000. Next slide.
Joy, I'm going to interrupt you. Sorry, Joy, this is Jeannie. I'm going to interrupt you for a minute, please. Maybe I could ask you, please, to just turn off your camera because we're having a little bit of trouble with the connection. That might stabilize.
Sorry. Okay.
No, that's okay. Thank you very much.
Okay. Our sustainability efforts started with the field health accreditation of our MNC past 5 years. No attempt at sustainability model further by Ronit and introduced. The model has 4 components that are interrelated: public policy, diversifying donors, supporting policy. I will stop here. Next slide, please. And hand it over to Ron for the next topic, our gap experience, the 4 gap support. Thank you, and Ron.
Hello, thank you, Tita Joy. For my topic, we will share to you our experience with the 4-GAC supported clinic during the maternal, newborn, and child health, or the MNCH project. Next slide, please. So we have the Zaragoza and Navotas. These are birthing clinics, and Bulacan and Eastern Samar are family planning clinics. So for the year 2021, our total average monthly operational expenses in all of these clinics is 27,410 Canadian dollars per month. So 70% of these expenses is for staff costs, 5% is for clinic and other supplies, and 11% is for rental cost of the facilities, 4% is for utilities, and the rest of the expenses covers the other expenses. So basically, this average monthly operational expenses is also the level of income that we need to achieve for us to be break even. So basically, the actual income is equals to the break even income, which I will further discuss on the next slide. Next slide, please. To easily illustrate the break-even income versus the actual income, uh, this is for the all clinics and the data is from 2021. In this graph, the red lines represents the break-even income of 27,410 per month. This is the data from my previous slide. And the blue line represents the actual income from PhilHealth or the Philippine Insurance Corporation paid services. So for 2021, our average actual income is 27,632 per month. For the income pattern, based on our experience, the month of January is consistently the highest earning month due to the backlogs or delay from the previous year's unpaid claims, which are being paid by PhilHealth on the month of January. As you can see also, there's a big drop on the income between the months of April and May because we have to close our clinics since most of our staff contracted COVID-19 and we have to shift to teleconsultation during this period. So for 2021, we have reached or we have achieved 79% of the break even. Although this is short by 21%, the good thing is we are nearing to break even. For the next slide, please. To follow up on the previous slide, we will show you the clinics data for each clinic. So for Saragossa Clinic, as I've mentioned earlier, this is a birthing facility. The average actual income is 8,493 per month versus the break-even income of 8,520 per month. This clinic has achieved 99.7% of the break-even. So basically, this is only short of 0.3%. This clinic is almost achieved the break-even. Next slide, please. For the Navotas Clinic, this is also a birthing facility. For the year 2021, the average actual income is 6,253 per month versus the break-even income, which is 8,150 per month. So this clinic achieved 77% of the break-even. So this is fall short of 33%. This clinic uh, the level of income is dropped between April and May, as I've mentioned earlier, that we have closed the clinic. So the income for this clinic affected on this month. Next slide, please. For the Bulacan Clinic, this clinic is a family planning clinic. For the year 2021, the average actual income is 5,967 per month versus the break-even income of 6,390 per month. So this clinic achieved 93% of the break-even. So they are short by 7% and also nearly to break-even. Next slide. This is the last clinic, the Eastern Summer. So this clinic is also a family planning clinic. This is located to rural areas wherein the population is dense. And the size of Eastern Summer Clinic is smaller compared to our other clinics. So their average actual income is 2,456 per month versus the break-even income of 4,350 per month. So they have achieved 56% break even. So that's the overview of our earned income from public funds. Next slide, please. Aside from public funds, we also, during the 2021, we have able to receive donation of contraceptive goods from Commission on Population and Department of Health, like contraceptive like implant, injectables, pills, and male condoms, this valued equivalent to 146 Canadian dollars. So that's it for my presentation. The next topic will be the context and future of sustainability model, which will be presented by Tito Jun. Thank you.
Hello, good morning to all. Next slide, please. So here I will try to pull back a bit and explain why we chose the components of the sustainability model that we have designed. The first context really is the pattern of health spending in the Philippines, and this is data from the WHO. The red part, that's out-of-pocket spending, spending that you do at the point of use of a service, and it's quite noticeable, and that we have very large amounts of share of OOPS in our spending, and this is something that we should note because policy-wise, it means that user fees are probably not viable as a means to do sustainability and probably not fair. It's also worth noting because we just had a new law called the Universal Healthcare Law, and PhilHealth, that's our insurance corporation, just released a year ago something about outpatient. They're designed for outpatient benefit package, and in that design, they are allowing up to 40% of the cost to be generated from user fees. So that's for private institutions like us. For government, it's not the same. But for private, they're designing it that way. And I think they have no sense of dividing private entities into profit or non-profit entities. So that's one fault in the law that we have now, and it's something that we should take note. Next, please. Okay, so another point that we can get from this pattern is that external aid for health is quite small in the country. So there's very little risk of aid dependence, unlike in other countries, I think. And the last point is that SHI, Social Health Insurance, or PhilHealth, is small, despite the laws and budgets that it is generating in the last few years. So a positive way to think about this is perhaps there's room for growth, and it may be that we can use this PhilHealth to do some form of sustainability for our clinics. So next slide, please. So this is just to highlight the great difference between the Philippines and Canada. So the red part, you can see that Canadian out-of-pocket spending is quite low and consistently low, unlike ours, that's quite large and consistently large. And the main difference also is the large component of public spending for health in Canada, unlike ours. Next slide, please. So number two context that we should take note in designing sustainability is the constant threat to SRHR in our country. That's quite specific to SRHR because of our Catholic history and the strength of conservative forces in the country. So opposition to SRHR is all throughout our government, from the executive, legislative to the judiciary, and from the national to the local level. That's also one unique feature in the country, is that we have great devolved powers to local governments, 1,600 plus local governments. So it's difficult to have consistent policy with regards to SRHR. Sometimes you have governments that local governments that oppose them despite the national government supporting SRHR. So securing SRHR must always be a part of sustainability. That's one lesson that we have learned in our years of into this advocacy. Next slide, please. Okay, so to place those two contexts in the model that we are following right now, context one informs our point about tapping public funds for and goods for clinics and not relying on user fees or more out-of-pocket spending, and also in our attempt to use more external donors, diversified if possible, or increasing the contribution if possible. But those two components stems from context one, the pattern of health spending in the country. And context two, we think that nonprofit health providers in SRHR has a great role to play in ensuring security of SRHR. I like to think that if we call on food security as an important part of a government response or national response to food, SRHR in the country is similar to that one. We need to constantly defend SRHR from opposite opponents. Next slide, please. Okay, so I will now talk about the four components of our sustainability model. The first one is about public funds and goods for clinics. So what we can do in the immediate future is, one, expand what we are currently doing now. So we earn really mainly from implants. So if we can sustain those supplies or enlarge those supplies, then we will earn more. But to be frank and honest, it's a narrow base of income, and we do need to expand, diversify the types of services that gets paid by PhilHealth. So in that way, we are exploring ways to branch into other services that PhilHealth will pay, like surgical family planning or cryotherapy. That's treatment when you have precancerous lesions found via cervical cancer screening. That will need an upgraded facility, maybe an ambulatory surgical clinic type of facility or a primary care facility. We need to do the studies and the pros and cons of each one. Next slide, please. Okay. We need also to carve out specific policies for nonprofit health providers. That's also one part of the problem in our country. As I said earlier, the legal context usually is to divide facilities as private and government, and for private, the policy just assumes that all private facilities are for profit. So in this sense, we need to develop policy proposals to the Department of Health or PhilHealth that will cater more to income support for nonprofit health providers. So three items are worth noting. One, we can probably these are proposals, no? So the chance of success is not certain. But one, we can do accredited mobile clinics that will cater to underserved and marginalized areas, because that's what nonprofits usually do. We tried proposing accredited mobile clinics for general use, and that was turned down by the Department of Health. So our thinking right now is if we narrow it down to use in certain localities, then maybe there's a chance that it will pass. Number two is to do point of care PhilHealth enrollment for youth using SRH services, because our policy right now is those under 21 are covered by their parents' insurance in PhilHealth, and that is a barrier for use by young people, not just minors, but even single young persons, maybe 18, 19, 20, who want to do contraception but are not open to using their parents' insurance coverage to gain access, financial access to that service. And the third is to try to accredit a freestanding SRH facility that will pool together the various SRH services that's currently being paid by PhilHealth. It will simplify things for nonprofit health providers like us. Like if you have a facility that's authorized and will be paid for to do family planning, HIV, cervical cancer screening and treatment, and all the other SRH services, that will benefit facilities like us. Next slide, please. In terms of diversifying and expanding external donors, well, it's similar to what Interparis, I think, is doing. We need dedicated fundraising communications team to promote the work that we do and directly solicit support from individual or institutional donors. And maybe develop mechanisms so that they can easily donate even small amounts. The small but many approach that has been developed through electronic means of fund transfers. Next slide, please. Next, please. Okay. And finally, securing SRHR. This is something that we are consistently doing also. We need to just continue it, basically to not let our guard down, still keep on developing consistent support for SRHR and monitor any types of restrictions that may go on in various localities. Next slide, please. So our takeaway message is from our experience, SRHR sustainability is possible, it's viable. We need to do some more work and investment and time to get over the hump. Thank you.
Great. Thank you so much, all of you from Likaan. That was fantastic and really interesting to be able to learn more about the work that you're doing. So in terms of just moving forward, I'm going to just ask a few questions and a few clarifying things, pull it together a little bit, and then I will open up the floor to questions. We're doing beautifully for time, so we're all good on that front. And so just in terms of maybe a couple of questions to anybody from the Likaan team who wants to expand on a couple of points that you touched on, and then I will make some summative comments. But I'm wondering if you could discuss a little bit more the linkages between your community engagement model and the actual clinics. So I think that came out at the beginning, but we had a little bit of difficulty with the sound. And so I think it's such an integral part of the model, but maybe you could pull it together a little bit more for us of how community engagement strategies and your relationships with the communities feed into your clinic model. And I put that out to any of the three of you who want to respond.
I'll respond. I think Joy's link is
No worries.
stuttering right now. Okay.
The realities of Zoom meetings. It's all good.
Yes,
Thank you.
of Zoom meeting. Okay, so we do community volunteers. So that's an integral part of our work. We also employ community mobilizers. So a few community mobilizers are assigned to generate as many community volunteers as possible So in areas where we first start with our clinics, the point is to inform them about the services that we do and to explain many things about SRHR that are usually enveloped in misinformation, disinformation that comes from conservative forces. So to explain that contraceptives do not make them sick or are not do not make people want to have sex more, things like that. Those are the types of information that you need to do at the beginning, and later it's more about community volunteers helping people from communities to track where our clinics are, the hours that we work, and how to get to those facilities. In in our experience, among poor people, they are worried about just stepping into clinics because they have had usually bad experience with some facilities that are not welcoming to people. So you do need some sort of um, push or encouragement for people to try out the facilities and the services.
Okay, thanks very much. So that sounds like it's about trust and the building relationships of trust, which is, essential. I'm also curious, maybe just to follow up on that a little bit more. That was the community piece. I also noted down about the advocacy, and you mentioned throughout all of you in your presentations different moments where you were at the moment advocating with DPHIL, it sounds like, around what kinds of things are reimbursed, et cetera. Maybe you could talk to us a little bit more about the relationship you've formed with DPHIL, in that it seems to be a central part of your financing model. Just in terms of how you interact with them, what kinds of proposals you're bringing to the table at the moment.
Okay. When when we started our project with this GAC supported project in 2016, the only facility that gets paid for family planning are birthing clinics. So the message seems like you have to give birth first before you can get paid for by the insurance corporation. So that's that's something we tried at first, but then we said it's quite limiting because what if people want to prevent their first births? Is that something that government will not pay for? So uh, in our relationship with the Department of Health, we asked them, what if we develop something like a facility, a family planning facility that can get uh, recognized and accredited by the health department and PhilHealth, and they said they're not interested. But they also said that if you like, then draft the administrative order and we'll take a look. So that's what we did. We drafted an administrative order, pushed it through a mechanism called the National Implementation Team that was formed after the reproductive health law was passed. It's sort of a coordinating body composed of government agencies and CSOs. And Likaan is one of several CSOs in that body. And through that mechanism of a coordinating body, we managed to get that administrative order passed, and I think a year or two later, PhilHealth finally acted and issued a circular recognizing that type of facility and starting to pay for them. So
That's a great-
that's how things work in the country. It's quite a long process, but you push and you push and you push, and sometimes you get something in return.
Okay, Thank you. I mean, I think that sounds like a big success in terms of your advocacy efforts and what it opened up in terms of the kinds of financing that was then available to support the work that you're doing. So I think that's an exciting thing to hear. And I think that it shows us also that public financing is an innovative form of financing in terms of being able to use public funds to support the work that nonprofits are doing. And you also somebody mentioned, I think, Ronit, that you are able to get supplies, also contraceptives, et cetera, from the ministry. Is that open to all of the partners with the ministry, for profit and nonprofit? Does everybody get free supplies?
You take that, Ronit?
Yes. Uh, for the other CSO, they're also getting supplies from the DOH. They're just having to have a partnership agreement and reportings of clinic datas. The supplies should be submitted to DOH.
And are
But for the
for-
private,
Mm.
I think they are not giving. The DOH are not giving supplies to the private.
Okay, so nonprofits have a particular relationship that way with them. So that's interesting too, in terms of ways that they're trying to spread out the support and the financing options.
And
Go ahead.
I'd like to add also that part of the success of that contraceptive distribution can be attributed to the reproductive health law. So it was written into the law that the government must coordinate, help with CSOs in implementing the law, and part of that type of help is distributing supplies through CSO networks.
Oh, okay.
Private facilities may join, but they are restricted from charging for those. So by that mechanism alone, I think they're not interested in getting those supplies.
Sure, fair enough. Okay, thank you. And I think you're speaking to several of the points that occurred to me while you were talking, in terms of just wrapping it up and moving us into questions. I mean, it strikes me that you have been working on this for several years now. And that, I think, reminds us that this is a long-term endeavor, that this isn't an overnight story, that building relationships of trust with communities as well as with the public provider, DPHIL, et cetera, is a long-term endeavor. It does rely on the advocacy efforts that you sound like you have been engaged in for a long, long time. So advocacy is also a big piece of the work. So what strikes me is that this is a model where you have a sort of wraparound set of things going on, everything from the community-based work and engagement to building trust, to actually doing the service delivery, to advocating for it to expand and have other things brought under the umbrella. So I think it's a lot of food for thought for us as I open it up for questions, and also speaks to what nonprofits do that's different than private actors. So I think even your comment, June, about the user fees and some of the weaknesses in the new law around universal health care of being allowed to have up to 40% service cost for user fees is really not done with a lens towards marginalized peoples and out-of-pocket spending. So there's a lot of food for thought for us as we move into this, thinking about health as a public good that really deserves public financing. I'm going to stop talking at this point and just turn it over now. We have about 30 to 40 minutes available to us up to that time. And I just invite questions. I'll be looking